I have to first say that my very first audience number was when I was 12 years old. I had 2,000 people as an audience, and this is a different audience.
It's a better audience.
Better audience, exactly. Well, let's start. It's a pleasure for me to share with you aspect of the work that started 30 years ago on the role of inflammation in development of tumorigenesis and angiogenesis, and some perspective for prevention and therapy of cancer that I developed in recent years as the extension of my previous work. To begin with, I reflect the world vision of Rumi, who said, if your ears become your eyes, you can see me. This is particularly interesting for me because most of my research studies were done with the ocular tissue. And even if I'm giving a talk to the urology research people, I said the way to urinary tract is through the eyes. So that's my work. I hope this lecture is not another art of transferring information from the notes of the lecturer to the notes of the audience without passing through the minds of either. I hope I can stimulate some thoughts. What I'm going to discuss is briefly a recent definition of acute and chronic inflammation, yin and yang of immunity in health and chronic diseases, aging, with emphasis on cancer. I would briefly overview the accidental discoveries that we had since 1980s on the developmental phases of inflammation-induced altered immune dynamics that resulted in tumorigenesis and angiogenesis, and the challenges that I experienced at the National Cancer Institute since 1998. Wow, what an experience. Then I would present you some assessment of cancer-targeted therapy, which I believe it's a distorted picture of research and clinical trials with repeated failed outcome. Then a few words on the future perspective on research and design of clinical trials. Inflammation has been known for 5,000 years, particularly in Egypt. And in first century, Cornelius, and then later on in the 19th century, Virchow described the sign of inflammation that are 4 redness, swelling with heat and pain. This is what we know about inflammation for years and years. Ibn Sina, who was the father of science, an Iranian scientist, described septicemia or sepsis as was accompanied by fever. Some of you may know that cap and gown for graduation was designed as a respect for Ibn Sina, father of science. A few historical observations. I mentioned these because they have been ignored, minimized, and dismissed by the cancer community, and I like to present these historical events to you. In 1909, Ehrlich, when the microscope was invented, observed that tumor cells are recognized and eliminated by immune cells. In 1911, Peyton Ross isolated virus-causing cancers, and it took the community to accept this concept about 50 years. He received a Nobel Prize in 1966 because of his very methodical, insightful studies to prove the virus can cause inflammation, well, not only inflammation, but cancer. Well, if it took him that long, perhaps for somebody who is not male, who is not in the same ethnicity, or not the same nationality, it would take maybe 4 times as much to prove the discoveries that I'm going to show you today. In 1957, Sir Macfarlane Burnet, through a very insightful examination of his colleagues' work on different areas of biology, described immune surveillance, or the body's ability to kill cancer cells. All these have been almost absent in the research studies that cancer community has taken on, and I will show you why. The reason is that despite 20 million articles that are on cancer topics alone, there are still debates, controversies, misunderstanding, and misinformation on the role of inflammation, particularly with regard to cancer, whether inflammation is protective in preventing cancer or it is causing cancer. Okay, so recent definition of inflammation that I'm happy to describe based on the immune surveillance theory are as such. Inflammation has been known, acute inflammation has been known as a self-terminating, highly regulated property of immunity, but we recently described acute inflammation as possessing 2 biologically opposing arms called yin, or pro-inflammatory apoptosis or tumoricidal, and yang, or anti-inflammatory wound healing and termination factor, or tumorigenic, which terminates the yang. It initiates by evoking an elaborate and specific crosstalk between immune and non-immune system to protect the body against all external and internal harmful agents throughout the body, throughout the life of a person. Internal or external stimuli or foreign body includes all the carcinogens that we are exposed to, the environmental, biological, and internal factors such as cancerous cells, which are, we are talking about cancer. So cancerous cells or other defective proteins or DNA or oxidized material or complex cells that are useless to the body is viewed as a stimuli, as a foreign body, and the biology of body of a good, effective immunity can destroy and make the body to be healthy all the time. This is a schematic representation of a biphasic property of immune cells, yin and yang. Let me see if I can show it. Oops, go back. Let me go back. Yeah, I can do it. Here it is. Yeah. Right, yes, thank you. The yin and yang, it took me about a year to develop this one figure to see what are the yin factors and what are the yang factors, because the literature is very, very confusing. Anyway, very briefly, a stimuli, a foreign entity that is threatening the body, can stimulate one or more of immune cells, antigen-presenting cells, macrophages, natural killer cells, or dendritic cells, for the purpose, can stimulate for the purpose of destroying the foreign bodies. They can express toll-like receptor, for example, as well as a large number of appropriate oxidants, hydrogen peroxide, superoxide, vasoactive materials such as histamine, and a number of cytokines and chemokines, as I said, for the purpose of destroying and facing the antigen or allergen or infective agents, and also to destroy the infected tissue. These toxicity that are generated in the tissue has to be exactly and precisely neutralized by some factors with opposing biology property. For example, growth factors. That's what we call it, wound healing. So in the oops. I think it's not as sensitive. So in the, is this working?
There's one on the top of the podium right there, silver, right in.
Yeah, it's right there.
Oh, thank you very much. So the death factors, which are a number of these agents, has to be neutralized by the growth factors or the yang, and they have to be balanced at all the time. This is considered acute inflammation. Acute inflammation is intimately facilitated by vasculature in both yin and yang. Vasculature are the gatekeepers of the inflammatory cells and participate in both yin and yang processes. This is another version, more complicated of the story of yin and yang. It's not just immune system, immune cells, and the stimuli can activate immune system, innate and adaptive immunity. I mentioned vasculature, neuroendocrine get involved, tissue, adipose tissue, as well as metabolism and bioenergetic from the mitochondria. They all get involved. It's like a molecular village to keep acute inflammation and the yin and yang processes in balance, checked. So briefly, the yin events is responsible for production of death signals and toxin to destroy both the enemy and the injured host cell. And the yang is responsible for removal of toxin debris and from the battlefield, and to repair and reconstruct host cell and terminate inflammation. The outcome of an acute inflammation, which is self-terminating and good for your body, is lymphocyte-derived clonal expansion, increased synthesis of allergen and pathogen-specific antibody and plasma cells, and memory cells. So the next time your body is exposed to the same type of pathogen, the body is ready to unleash appropriate defense by, for example, expressing antibodies. One little mention that each immune cell has the capacity to directly and indirectly influence activation, proliferation, differentiation, growth, and maturation, or we call it polarization of other cells. For example, if the mast cells are activated and cannot defend properly, they call on eosinophils, and later they may call on macrophages. And they can also influence the non-immune cells, such as epithelial cell or endothelial cell. This is important because I want to show you how wrong we are for therapeutic aspect of cancer. Okay, what is unresolved inflammation? It's when the friend, which is acute inflammation, turns into your enemy, to the body's enemy. It's the loss of balance between yin and yang. Oxidative stress, they mentioned that, yesterday it was mentioned that leishmania can cause decreased tumor necrosis factor. There is a reason. The oxidative stress or antigen load can induce continuous activation of antigen-presenting cells and cause expression and co-expression of apoptotic and wound healing factors, changing the dynamics of the immunity in favor of growth arresting in some tissue or growth promoting in other tissues. This condition signals for immune suppression. You know, when you are exposed so much with oxidative stress, from one hand, the dendritic cells, for example, is activated, but it switches to the other side that give me some wound healing, give me some wound healing. But then the oxidative stress remains. So there is a chaos in the tissue, and I will describe why. For example, oxidative stress induces changes of inherent polarity of immune responses. A stimuli can cause polarization of dendritic cells, let's say immature dendritic cells, which are more tumorocidal, to tumorigenic property of dendritic cells. They have biphasic properties. So they are more prone to generate wound healing factors. Similarly, macrophages can be polarized to macrophage 1, macrophage 2. The ratio goes down, and this is considered as tumor-associated macrophages. Tumor-associated mast cells are the same. We consider this as leaky mast cells. They all can participate in also influencing the adaptive immunity, cell-mediated immunity, and humoral immunity. So the Th1, Th2 ratio changes, and they all participate in increasing immune suppression, a decrease in apoptosis. For example, tumor necrosis factor is not equivalent to its growth factor. So then redox potential decreases, angiogenesis increases, and growth signals are increased in certain tissue, which are immune responsive tissue. I describe it in a bit. So unresolved inflammation, basically, we considered it as immune tsunami. Inflammation differentially impact immune privileged, like blood-brain barrier, central nervous system, neuroretinal tissue, etc., or immune responsive tissue, like epithelial cell, endothelial cell. There is a reason that you have a neurodegenerative disease or cancer. This is a very complicated figure, but I would just like to mention that in the A, this is acute inflammation, self-terminating, apoptosis occurs, tissue repair occurs, these are balanced, and the vascular hyperpermeability lead to vascular integrity, everything is fine and dandy, so you don't have a problem. However, if the stimulation of tissue continues, particularly during aging process, you are activating the mutation of the DNA of both immune and non-immune tissues, and there are altered signals. As I said, they become like immune tsunami, and the signals, if there is more apoptosis in the immune privileged tissue, you end up having neurodegenerative diseases during aging. And if there is more wound healing in the tissue, in the immune responsive tissue, you start cell growth and cancer and angiogenesis. This is very complicated, but I hope you are stimulated enough to read the relevant papers. Okay, we propose that genetic defects in apoptotic or wound healing pathway or antigen load can induce exaggeration of expression of cell-mediated immunity or humoral immunity responses, and could create immunological chaos, or as I mentioned, immune tsunami, that would contribute to accumulation of response mismatches in target tissue, leading to initiation and progression of diseases or cancer, chronic diseases. A few words about aging. Wisdom comes with age, but sometimes age comes alone. This is very true for a lot of us. Okay, we hypothesize that chronic inflammation is a common denominator in genesis and progression of age-associated chronic disease, all age-associated chronic diseases. And in 2009, we started to connect the dots and initiate a roadmap of what's going on. Okay, briefly, longevity and persistent inflammation are comorbidity, comortality risk factors in increasing the incidence of chronic diseases such as many allergies, asthma, emphysema, ocular or skin reactions, adult onset diabetes, osteoporosis, atherosclerosis, stroke, Alzheimer's, etc., and many site-specific cancers. I mentioned Alzheimer's, and I remember my mentor at the University of Pennsylvania, David Krzyzewski, who had this wonderful sense of humor. At 86, he was on a wheelchair in a major meeting. As soon as he saw me, he says, "Come here, come here. I was telling these people that I still chase women, but I don't know why." So that's the As I mentioned, the inflammatory conditions and infections, along with changes in hormonal and metabolism and physiology of the aging body, can initiate immune response compromises. And in different tissue, it impacts differently. For example, in vasculature, you have different changes of vascular toning or angiogenesis, DNA damages in some other tissues, growth or necrosis in some other tissues, and changes in oxidoredox potential, which manifest themselves in different tissue as different diseases. But they are not different. The root causes of all this is the same, and it's chronic inflammation. That's what we hypothesize, that they are interrelated. And these diseases are like diabetes or cardiovascular diseases, autoimmune disease, or neoplasia and cancer. Okay, time may be a great healer, but it's a lousy beautician, and we all know that. Therefore, longevity and rate of susceptibility and severity of chronic disabling diseases vary among individuals because of the complex combination of interaction and heterogeneity between intrinsic and extrinsic factors that would determine the biology of body. So not everybody ages at the same rate. There is some hope. So healthy aging basically is maintenance of proper functioning of the stem cells, which is the giant manufacturers of your immune cells, and it is a key to body's resistance toward oxidative stress and delaying the onset of chronic diseases. All right, a few words on the experiments that we accidentally came into in 1980s. I have to mention and emphasize that in 1980s, we were not involved in cancer research. And I had no idea of the importance or significance of the findings that I'm going to describe briefly to cancer research until I came to the National Cancer Institute in 1998. Wow, what an experience. This has become a real gold mine for me, which is still taking me to different levels of discoveries. This is a picture of my colleagues at the University of Pennsylvania, Department of Ophthalmology. John Rocky was the head of the laboratory at which was inflammatory ocular diseases. And the advantage of being short is you are always in the front row. These are the university, the acknowledgement from the University of Pennsylvania. John Rocky, as I mentioned, was the head of the lab, and I had several wonderful colleagues. We were very productive. Everybody was contributing to the studies until I came to the National Cancer Institute in 1998. The list of people who opposed what I was saying, who denied the opportunity for me to continue this work, the list is very long, and they are presented in different formats. However, I have to mention the wonderful work of Alan Hoofring at the NIH Medical Arts, who was wonderful in taking ideas step by step and developing the way I wanted to be developed. So many of the figures that you saw is his contribution. Basically, we challenged the guinea pig eye by an antigen we synthesized, fluorescein ovalbumin. We challenge the eye bilaterally, unilaterally, with or without antigen, with or without adjuvant infective agents or tumor-promoting agent for up to 30 months. Recent reanalysis of the series of data that were published demonstrated at least 3 phases of immune dysfunction in conjunctival associated lymphoid tissue that led to tumorigenesis and angiogenesis. These were the initial data we published. In the acute phase, which was between 9 to 12 days of stimulation of the ocular tissue, we saw tearing, scratching, vascular hyperpermeability, IgE-mediated mast cell degranulation. And I think this is very detailed. I won't go through it. This is acute inflammation, tearing, and edema. Some milky secretion from the hyperpermeability of the vasculature. In the intermediate phase, which occurred within 12 months, within 2 months, we saw downregulation phenomena, minimal clinical reaction, and decrease or exhaustion of number of mast cells. This became like, we didn't see much. However, infiltration of eosinophil into goblet cells and mucus secretion was noted. This is not a strawberry shortcake. This is eosinophil infiltration into ocular secretion after repeated challenges. This is eosinophil infiltration into the goblet cells. In the chronic phase, which took 12 to 30 months, we noticed induction of tumor-like lesions in conjunctival associated lymphoid tissue, angiogenesis, lymphoid hyperplasia, and swollen goblet cells, leaky mast cells, and lymphoid capsular, loss of lymphoid capsular integrity, and extensive epithelial thickening and thinning, growth and necrosis, almost always in the same tissue. This is a clinical reaction. You see tumor-like lesion, upper and lower conjunctiva, and extensive angiogenesis. The cross-sectional area of massive hyperplastic tissue in some animals were at least 5 times greater than normal or untreated animals. The story is very long, but I'm giving you just highlights of it. This is a histopathology of hyperplastic tissue, conjunctival tissue, the loss of capsular integrity of the lymphoid tissue, and small or large different sizes of lymphocytes are noted here, thickening or thinning of the epithelial tissue. And I think I have to bypass this. The leaky mast cells can contribute to angiogenesis by inhibiting the angiogenic inhibitors and increasing the angiogenic stimuli. Basically, what we have demonstrated is these 3 phases of acute inflammation. This is yin and yang, which is acute, reversible, the increased reversibility when it's in the earliest stages, the intermediate stage, and late phase. And most of the cancer research has been done at these stages. This is the first and only demonstration of a direct link between inflammation and tumor development. I will show you more data. And we hypothesize that aging can increase the risk toward tumor development. When you are younger, your body can compensate or fight the antigen that you are exposed with. Okay, this is the list of contribution that I presented at the National Cancer Institute since 1998. The story is very interesting now, but it was very much a struggle for me. When I came to NCI and read a lot of different papers to develop some concept for diagnosis, molecular diagnosis of cancer, I read and I found out that our own work was very much related to this with so much excitement. So I immediately proposed that inflammatory mediators are potentially ideal target for diagnosis, prevention, and therapy of cancer. My God, they looks at me, wow, that how dare you, you develop such a thing, you shouldn't be doing this. So immediately I knew something politically was uncomfortable. I sent the idea to a colleague at the Hopkins. He sent me back before knowing that I'm not within the system, because he was within the system. So he immediately sent me a note that this is a novel idea. This is 1998. Nobody was working extensively on inflammation. So everybody was rejecting what I was saying, and the few colleagues who were involved in inflammation research, they were all desiring to have a direct role of inflammation associated with cancer. So then I designed the clinical trial. Knowing I was a woman from Iran, a Muslim, I had to be at least 4 times better than the male colleagues. But still, you had to struggle. Anyway, so I proposed a number of concepts for the very first time, and in the midst of such a political harassment, intellectual harassment, I managed to publish an NCI invention in 2005. You have no idea what I went through, but I'm happy. I standardized cancer biomarker criteria by developing data elements that is good for all cancer biomarker, and it was a foundation for a database. And in 2014, just last year, reanalyzing our own data, I found out that we have the very first evidence for sequential interaction and synergies between host and recruited immune cells through vasculature. Furthermore, in 2015, working with some colleagues, epidemiologists, I found out that there was no report on how low-level carcinogens can end up having cancer, because there was no early responses, and I thought we had the early responses that I showed you. So let's go. As Walt Disney says, the flower that blossoms in adversity is the rarest and most beautiful of all. I think it doesn't want to go anywhere. Okay. So there is 3 stages of truth in governmental science. It's a severe opposition, denial and rejection, and then acceptance as it's an ordinary fact. Now everybody is working on inflammation. I have all the documents. In 2004, the Time magazine said the secret killer is inflammation that causes heart disease, cancer, Alzheimer's, and other things. Thank you very much. Others are, no, I'm not done. I'm not done yet. How much time do I have?
5 minutes.
Oh, okay, thank you. I have a lot to say. All right, we passed this. In 1910, cancer was not in radar screen for a statistic of a killer's disease. In 2013, the American Association for Cancer Research announced shamelessly that 1 out of every 3 women and 1 out of every 2 men would develop cancer in their lifetime. So the fundamental question is why we have not solved cancer for decades, or is cancer outsmarting scientists? I also published something that we have taken a yard from the public and given back less than an inch. Okay, as Albert Einstein says, those who are privileged to know have the responsibility to act. This is a list of circumstantial evidence between prior injuries to cancer. For example, we all know that long-term colitis can rise to colon cancer and so forth and so on. I don't have time. These are circumstantial evidence. Okay. I have to mention the few facts. In 2008, 7.6 million people died of cancer worldwide, as reported by WHO. In 2012, the number increased, and 8.2 million died of cancer. Similarly, in 2008, the same year, $1.6 trillion, trillion, it's a T, was spent in 1 year on cancer treatment and care. And as I mentioned, and this is a graph of the chart reported by WHO of different cancers, lung cancers, and the cases of cancer and those who died of cancer. Now, assessment of cancer targeted therapies. And I have to mention in 1971, President Nixon, through Cancer Act, increased the level of funding for NCI to $1.6 billion so that the cancer would be solved in 8 years. 40 years has gone by, and trillions of dollars, at least 10 trillions. I'm writing a detailed article and a book on the subject, so I'm very passionate about it. So let's pass this. There are reports that how many clinical trials are ongoing. Targeted therapies or claim personalized or precision medicine is heavy investment on infinite number of genetic mutations, which we call it molecular false flag in the chaotic cancer molecular landscape, and a strategy is based on a false foundation. So when you have a false foundation, you don't get anywhere except spending money. So this is a list of examples of the targeted therapy that has been developed for different cancers. What Peyton Ross said the best is a hypothesis is best known by its fruit. What has been those of somatic mutation hypothesis? It has resulted in no good thing as concerns the cancer problem, but the most serious result is the effect on people who work on it. It acts as a tranquilizer. This is a lot. And he said this long before mutation studies was put on steroid. I have this in another publication. So they claim targeted therapy, the outcome has failure rates of 90%. How do you accept this? How can you accept it? It's admitted by government even. So it's easier to mislead many men than one. And I think you cannot mislead a woman. I think I can, this is a wonderful movie, 30 seconds, but I can pass. So the money talks. And this is the diagram for genetic mutation. Which one of these do you want to cure and inhibit so that you can cure cancer? This, I would like this as a design of my dress. That's very nice design. Okay, why we are wrong in the targeted therapies? Targeted therapy, I developed this dartboard. The target is marked as number 1, which is imbalanced tumoricidal and tumorigenic property of the cancer surveillance, or yin and yang. Not many people are working on this subject. However, when they get into the cancer, the tsunami, they develop not one target, not 2, 4, 5, and they consider this chemotherapy, and they cause life-threatening side effects. Cachexia, anorexia, sarcopenia, thromboembolism, and multiple organ failure is very similar symptoms when you are affected by potent pathogens that cause multiple organ failure. So then they say, oh, we have drug resistance. It's not drug resistant. It's the compensatory molecular activation of tissues that come back. You know, after you inhibit one growth factor, the compensatory effect can lead to cancer. So these are several steps from acute target, and there are potent apoptotic or poison, and they are heavily invested in studying genetic mutation with infinite possibility that site-specific cancer generate. They ignore the compensatory activity of immune and non-immune cell, and they fail to investigate systematically what causes cancer. This I showed, I would not go through it. We are very advanced in technologies. And there are, I think the recent immunotherapy is wrong also. It causes so many side effects. I think we developed a double vision on the mission of cancer. Profitable culture of sick care versus healthcare by big pharma and food industry has been created. Cancer cells are viewed as an opportunistic defective cells, inherently possess independent oncogene property like viruses, parasites, or bacteria, and coexist within multicellular layer of host. Cancer biology, again, growth of cancer cell is routinely monitored by immune surveillance as any other infective agents or viruses or microorganisms. Cancer become a threat to the body and act independently with its oncogene to take over body's machinery when the dynamics of immunity alters, particularly during aging process. Okay, I think I can concluding remark. We need systematic studies to see what causes cancer, and in different tissues, different cells participate, and we don't even know the composition of immune and non-immune cell in different site-specific tissue, but we are designing therapies. So I think I can bypass this one, yin and yang. We have to promote yin and yang. And the drug development, usually the combination of sulfidyl combining agent, I proposed, for example, years ago, captopril, aspirin, and they are using it now without ever mentioning any credit to me, which is fine. Our commitment to serve the public should be higher, calling stronger than our obstacles that I have experienced a lot. But this talk is dedicated to the victims of cancer. And I leave you with a couple of messages, philosophical messages, that he who latches onto the branch, which are all these little things, breaks and fall. He who holds onto the tree, all branches of his. This is from Shams Tabriz, who was mentor to Rumi. And I would end by saying that Rumi would say, they will ask you what you have produced. Say to them, except for love, what else can a lover produce? I love what I do. And thank you very much.